Well, good afternoon, everyone, and welcome to today's webinar, Optimizing Nutrition Care Through the Gastroparesis Journey. I'm Angela Buffington Johnson, and I will be your host and moderator. Thank you for joining us, and please feel free to submit questions throughout the presentation in the chat using the chat feature. You'll see that at the bottom of your screen. We will address those questions during the Q&A session at the end. Gastroparesis can significantly impact nutritional status, symptom management, and quality of life. Today's program will provide practical, evidence-based strategies to help healthcare professionals better support patients living with this condition. It is my pleasure to introduce our presenter today, Ashley Judson. She is the founder of Nutrition by Ashley. She is a registered dietitian, and Nutrition by Ashley is a virtual private practice specializing in gut health and complex gastrointestinal conditions. Ashley holds a master's degree in sports nutrition from the University of Colorado and has extensive experience helping patients help patients navigate digestive health challenges. She is also an active leader in the profession, serving as chair-elect of the Washington State Academy of Nutrition and Dietetics. Today, Ashley will share practical approaches to nutrition management across the gastroparesis continuum, including symptom management, dietary modifications, and patient-centered care strategies. So please join me in welcoming Ashley Judson. And before we do that, I will just quickly mention that we are a humanitarian. Intera therapy is a humanitarian device, and we have FDA approval for that. As you can see here, our indication statement states that we are indicated for the treatment of the symptoms of nausea and vomiting associated with gastroparesis. So again, welcome, Ashley, and please go ahead and take it away.
Thank you so much, Angela. I'm really excited to be here with everyone. This is a topic that I'm incredibly passionate about. One that when I started as a dietitian actually gave me quite a bit of fear, but over time it's become my favorite area as being a GI dietitian. And I really hope that you leave today with some practical tools that can be implemented in your practices, even if you have a lack of access to a dietitian. Okay, so let's start with just an overview of a diagnosis of gastroparesis. So gastroparesis is defined as delayed gastric emptying in the absence of mechanical obstruction. Symptoms typically occur after meals, with key indicators to monitor being nausea and vomiting. Though those are cardinal symptoms, we often see other symptoms such as early satiety, postprandial fullness, epigastric pain, discomfort, and also bloating. So when we think about management of gastroparesis, for anyone who works in this field, I'm sure you're not surprised to hear that it's really complicated. The condition itself can present with different varieties of severity. So someone may have mild, someone may have severe, and the symptoms severity doesn't always match the degree with which we see delayed gastric emptying in our gastric emptying study, which we'll talk about in a few slides. So because this can be really complicated, our treatment approach and the patient's condition can be pretty unpredictable over time. While medications can really help us reduce symptoms in patients, they do come with their own risk of side effects and could limit long-term use. And unfortunately, many patients have overlapping conditions that just make this clinical picture even more complicated. So in a summary, there's no real single treatment that fully addresses every symptom. So this really has to be a collaborative plan to support our patients appropriately. So this is a really busy slide, but there's a lot of valuable information that I really want you to take away and is a preface to what's to come next for this stepwise process. So treatment approaches could involve nutrition care, which we utilize as our first line of treatment right after diagnosis, or we hope after diagnosis. This is where we can hopefully initially manage the patient's symptoms perhaps prevent their progression to needing advanced therapies, all while understanding that even with the best intentioned plans, nutrition doesn't um, rule out advanced therapies because even with a nutrition plan, symptoms can certainly persist despite our best efforts. So, what are advanced therapies? Advanced therapies include medications and then surgical or procedural um, aspects like an enterotherapy placement. So, step-by-step method helps us with these advanced options. Dietitian's not heavily involved in these latter two, the medication and the surgical aspect, because I can't, as a dietitian, prescribe medications. I can't also implement a plan for a patient who may or may not meet the criteria for surgical. But I do find it's incredibly beneficial for us as providers, regardless of what field you're in, to have some idea of what this treatment process looks like and what could be implemented for the treatments. So this is just an algorithm that I find really helpful for, if you will, like a care roadmap. So with this, it can really help us by maintaining team focus, can foster collaborative care, which in my opinion can be one of the most valuable tools for us as providers so that we're working together to help the patient manage this condition. And then ultimately, we want to improve management. We want to help with treatment strategies that are decided by a collaborative team, not provide the patient with counter or contradictory information. So step one would be our diagnosis. So again, this is another process that a dietitian's not technically involved in. I'm not going to be ordering upper endoscopies or the gastric emptying study. That said, it's really important for us to know what happens through each of these processes. So diagnosis, we're looking for these cardinal symptoms, primarily nausea and vomiting. However, those may or may not be existing, and we might have other things like pain, early satiety, postprandial fullness. First and foremost, we should be ruling out any sort of mechanical obstruction. This may be done with an upper endoscopy. If we've ruled out mechanical obstruction, often we're going to move on to a delayed gastric emptying study, which we hope confirms the condition. And we have to consider some offending medications like the use of THC, patients who are on opioids, or these GLP agonists, which are certainly used in diabetes treatment, but now we're seeing them, of course, more and more with weight loss. They can all mimic delayed gastric emptying, so this may not give us an accurate picture of what's going on with the condition or their symptoms. So just taking a little bit to look through a gastric emptying study result. Here in the top, you see retention rates if it's considered normal. In the middle, retention rates if stomach emptying is actually considered rapid. And then we have our delayed confirmation of retention of stomach contents. As far as a dietitian goes, results from this GES, along with patients' observed symptoms or symptoms that I observe they report, can really help me inform treatment strategies when we're starting with this first line therapy of nutrition first. Our role is to help them manage their symptoms, finding ways that are most applicable for them while also being really thoughtful about feasibility. Do they have support at home? Do they have access to food, etc.? Despite all of this, there are limitations that we face as dietitians with these GES results. And for example, I might see someone who has mild gastric emptying per the gastric emptying study. However, they present with really severe symptoms. So where I start with a patient may be very different than what this test actually tells me might be going on in their body. So step two of this algorithm, which is a little confusing because we say it's the first line approach, but just thinking about this algorithm, it's step two. So a nutrition care plan, my hope is that we're providing tailored information to the patient, not just something that's scripted from nutrition education that's made by your clinical department or even an open source, which at the end I have some of those as well. And most hopefully, it's frequently assessed to accommodate any changes that the patient reports or observes. So they may start off with really severe symptoms, they may progress to mild, and then they might have this step back or regression to really severe. So helping them navigate that's really important. Core interventions, we'll talk about this in a few other slides. Limitations, as again, it could be that we just don't have resources like a GI dietitian or someone who is really confident with working with patients in the GI setting, particularly with gastroparesis. Doesn't directly address motility, so we can help them with their symptoms, but I'm not going to make an impact per se in the actual motility. That's a functional aspect. And then I'll also just mention there are definitely some insurance restrictions that could just totally eliminate the possibility of receiving dietitian services. So sadly, even if you have access to a dietitian, it doesn't mean that the patient's actually going to have access through their insurance. So what goes into this first line approach? There's a lot. So if we think about a dietitian going through an assessment, this usually happens in our initial assessment. We're really fortunate. I shouldn't say everyone, but dietitians tend to be really fortunate because we often have a larger block of time to spend with patients than, say, an MD or an APP. So we have often the time that we can do a really robust intake. It's not only important for me as a dietitian, but I find this incredibly important to share with that other provider that's involved, whomever referred, or maybe I'm referring to someone. So we have this real collaborative plan because patients don't feel like they always get to share everything with their doctor during those visits. Just the nature of the medical world these days. So this would involve things like gathering medical history, asking symptom patterns, what are relevant conditions, what is their current intake, what can they tolerate, what do they think they can tolerate, what do they think is triggering their symptoms regarding food, trying to get an evaluation of like a 24-hour recall. We as humans are notorious for overestimating or underreporting what we're eating, so having someone track this can be really beneficial. Looking at weight trends along with body composition, functional status, daily living abilities. This may literally be their ability to ambulate, how difficult that is, but it also may be living abilities with access to where they live. Can they go to the grocery store? Can they cook, etc. And then, not least of importance, but just listed here, incorporating lab results and micronutrient assessment. So, common deficiencies that we'll talk about later. So, hopefully, I'll give you some tools that you could use in your preliminary assessment that you don't have to have a dietitian. And this can really help us with managing nutrition deficiencies. So, again, our third and final step in this algorithm are our advanced therapies. So again, we have medications, things like prokinetics help stimulate peristalsis, antiemetics. Advanced therapies could also be our enterotherapy, or it may be surgical. Maybe they require or are a candidate for something like a G-POEM, or maybe there's someone who sadly needs nutrition support, and ideally we would place a jejunostomy tube. It's not advantageous to place a G tube in these patients due to the severity of their symptoms. Some of the essentials, I'm gonna probably harp on this a little bit too much today, but a lot of these therapies don't replace the need for nutrition therapy. Diet modification might still need to be monitored and modified after a procedure. There's still a malnutrition risk. With more optimal care, that certainly goes down, but pre-surgical status can indicate post-surgical malnutrition risk. And then if we can, we want the RD or dietitian involved in all stages. Okay, so now we're going to get into all of those components that I mentioned on that one slide. So expanding on these advanced therapies, we've got pharmacology, things like metoclopramide, domperidone, perculapride, or we've got these surgical aspects. Just a recap of those. So moving on to actual practical aspects of nutrition practice. One of the components is, I hope, looking at any pertinent medical diagnoses and history that the patient has, if you have access to this. I'm quite clinical when it comes to my assessment before I meet with a patient, and then I'm actually quite holistic in my interventions. Getting this clinical picture really helps me evaluate what else could be going on and what else I need to be looking at. Are there specific nutrient deficiencies that are at risk with one condition over another? Do they have an eating disorder history, which helps guide me in the appropriateness of a quote unquote diet? Or are they someone who has connective tissue disorder, which we see slowed motility. Often I'm going to see constipation paired with gastroparesis, which is not uncommon, but it could be exacerbated in these folks. So a comprehensive dietary intake, I find this to be a bit of a misnomer because dietary intake doesn't just assess diet. We're also looking for things like supplement intake. Are they someone who uses a substance, i.e., alcohol, THC? And what are sleep patterns like? How is this affecting their sleep? Pardon me, how is consumption affected by their sleep schedule? Are they having symptoms that are the worst in the nighttime? And so that keeps them up. So then they find themselves sleeping until early in the morning, late in the afternoon, which can interrupt their cycle of when they feel like they can eat based on a regular daily schedule. Perhaps one of the strongest components of the assessment is including patient-reported symptoms, the frequency with which these symptoms happen, and their severity, which, again, as I mentioned before, this is on a spectrum, so this can fluctuate, but it's really helpful to know where they are when we first assess them or when we're in follow-ups. Because symptoms can significantly impact their risk of malnutrition, it's important to know that patients' ability to maintain an optimal nutrition status can become quite complicated if they're experiencing these symptoms. So things like bloating, pain, vomiting, postprandial fullness aren't just discomfort, they're functional limitations that can determine whether the patient can or cannot meet their calorie, protein, hydration goals. Okay, so this is something that is very close to me and something I'm really compassionate about. And I'm going to try and not spend a lot of time on this, but I do want to emphasize that this population of individuals often experience weight stigma. So I think when some people generalize, think about gastroparesis, we think about they're going to be malnourished because they can't eat. They might present in a smaller body, which we associate with malnutrition. Yes, around 60%, according to some cohorts, may experience weight loss, but a lot of individuals actually maintain their weight or gain weight. I'll share that in my clinic, the latter is the most often the case. So I have an example of a patient that I wish I'd included in a case study, but I have some of those later that she just using weight before her diagnosis, she was around 175 pounds. And since her diagnosis, she's now at 280 pounds. And this is despite very, very minimal dietary intake. We're talking about maybe a protein or an oral nutrition supplement a day. And then she tries very hard to participate in dinner with her family in the evening, but it always makes her really sick. So things like refined carbohydrates, reduced activity, of course, insulin resistance, any use of steroids, and symptom-driven eating patterns. Patients tend to be really anxious, depressed with this condition, and so they can find themselves emotionally coping with food. And from a metabolic process, most of these patients are underfed with regard to calories and underfed with protein, but they have a pretty high intake of refined carbohydrates. And if we aren't using those metabolically, then we're storing those as fat. So patients gain weight and we see their fat mass increase, all while we see their lean muscle mass dropping down. So it's really important for me that we look beyond BMI. We look beyond the body shape. We look beyond the size. Sarcopenic obesity is a state of malnutrition where we have muscle mass and fat redistribution, which causes persistent deficient in vital nutrients. It's really hard to see. It's really hard to measure. Most of us don't have access to a body comp machine like a DEXA or others. So we really have to take into factors all of the other variables like diet, micronutrient storage, levels, etc., so that we can appropriately evaluate that. And sarcopenic obesity has been historically linked as a condition only in the elderly population or geriatric population, but we now know this is something that is seen in younger adults, particularly with chronic health diseases. So one of the tools that you could use in your clinical setting that perhaps could be part of an intake are validated screening tools. This is an example of a very quick, simple screening tool, most often used in like a triage of an emergency department, or it's taken or completed when someone maybe is admitted. And this helps us refer patients to a dietitian if they have a positive score. So it's very simple. You're just asking a few questions. Have you recently lost weight without trying? Yes or no, or they're unsure. If yes, how much weight? They have a weight loss score. Have you been eating poorly because of a decreased appetite? We get a score for that. And then you add those together. So if they have a score of 0 to 1, we determine that they're really not at risk just based on this screening. 2+, they're at risk. I mention this because this really might help drive who has the need for faster access to care, who might be at higher risk of malnutrition, who might need closer follow-ups, and if you have access to a dietitian, who might need an earlier referral for review and support. So I mentioned a case study. So again, this is something that is I hold very near my heart and I have a lot of compassion for. So I just want to go over a sort of a classic example that I see in clinic. So Mrs. J, she is a 54-year-old female. She does have a diagnosis of type 2 diabetes, which she was diagnosed with at the age of 36. She has long-standing type 2, which has sadly progressed to insulin dependency, mostly due to poorly managed diabetes. The question here is it chicken or egg? Was it poorly managed because of gastroparesis, or was this an all-encompassing issue where poorly managed diabetes then is the culprit for gastroparesis? Interestingly, she has no signs of weight loss. She has no signs of weight loss in her trends in her weight chart. But when we look at variables that we want to rule out for malnutrition, we did have access to a DEXA scan here, so she meets criteria for decreased fat mass, increased fat mass, decreased lean muscle mass. Her A1C is above 7. She has a mildly elevated CRP. Vitamin B12 is technically clinically normal, but we'll talk later about optimal ranges. Same with ferritin, and then she does have borderline deficiency. So 12 is technically the level where we consider vitamin D deficiency, but in someone with a compromised digestive tract, for me, this would warrant enough to have like a prescription, like the 50,000 international units for vitamin D for repletion. So this is a really great example of someone who doesn't present as malnourished, someone who might have a stigma placed against them, but they definitely do meet criteria for sarcopenic obesity. So moving on to micronutrient deficiencies, as I mentioned at the beginning, there are lots. I would say most vitamins, most minerals are at risk of deficiency. A lot of this is driven by poor intake. So patients often have really poor iron-rich food intake, whether it's from fortified foods or it's from animal proteins, because they really struggle with tolerance. This could also be due to PPI use, whether it's long-term use that's been directed by over the counter or if it's something that's appropriate for prescription. These low acid levels impair the breaking down and absorption of key nutrients. So we have these poorly broken down particles of food that enter into the small intestine that aren't readily available for proper uptake. So then we can see this decrease in vitamins and minerals. So iron and B12 are quite similar. Both are decreased in their availability for absorption, of course, due to intake, but also these low acid levels. Interestingly, for vitamin B12 and folate, we see sort of variable levels. So because the excess bacteria can directly take up and metabolize B12, it reduces the availability of this vitamin. So we tend to see a reduction in serum B12. With SIBO and folate, the bacteria can synthesize and they can actually produce extra folate, which might present as a high serum folate along with a low B12, not to complicate things. Thiamine, we tend to see more in our patients that have persistent vomiting, but this also could be poor intake. And it doesn't take long for thiamine to become deficient, around 2 to 3 weeks. And this can be really critical for autonomic nervous support. And so we really should evaluate this as well. Zinc, copper and magnesium mostly from poor intake, but we can also see competition of minerals with zinc and copper. So I often will have patients who are taking pretty high doses of zinc, either because they have been told they need to take that for immune support, or, that's been something they found online. Validated, zinc is very important for our immune system, but if we're taking enough zinc and persistently taking it, it competes with copper. So then we have poor copper absorption, so we can actually lead to copper deficiency. Vitamin C, most folks aren't getting in enough through their diet. I would argue this isn't just for folks that have gastroparesis, but we also need vitamin C as a tool to help us with iron absorption and transport. So this could also be a part of the puzzle for iron deficiency. So moving on to some more of our electrolytes. Vitamin D can be low. We don't have a lot of great sources of vitamin D from food other than things that are fortified or really fatty fishes, eggs. So some of those can be really hard for patients to tolerate. They may be lactose intolerant or they may not consume milk. Non-dairy milks are usually fortified with vitamin D, but again, it may be a struggle for them to get them in. And then if we expand fat-soluble vitamins and consider vitamins A, E, and K, we can have this impairment of fat absorption because, um, again, we need fat to digest these, but we also may see an interference of nutrients available for absorption in the small intestine, and that can decrease the release of CCK or cholecystokinin, which can weaken the signal of the pancreas to secrete enzymes and bile to help break down fat. So as a result, fats aren't properly broken down, and this can lead to malabsorption as well. So common symptoms, there's a lot here, but most importantly, what I want to point out is we can have symptoms and they may overlap with different vitamins and minerals. But on the next slide, I'll show optimal tests. And I think the two that stand out to me the most are folate and vitamin B12. This is not part of a standard metabolic panel. We aren't including this as a CMP or a CBC, but what we can see is normal hemoglobin, normal hematocrit. So we assume they don't have iron deficiency or anemia. But folate and vitamin B12 can show up as megaloblastic anemia, which would look on our results like an elevated MCH and MCV. In my opinion, that should prompt us to check folate and vitamin B12 to see if we actually have a deficiency in either of those. So optimal testing. Most of our clinical ranges, or all of our clinical ranges for these tests, of course, they vary between labs, are reference ranges for a general population. So they don't necessarily reflect adequate stores for someone who lives with a chronic condition, inflammation, restricted intake, etc. So I've listed some optimal tests to be done. Keep in mind, some of these might not be available to you at your clinic. So for example, folate, you may only have access to serum folate, which is great for the short term, but for acute changes over time, we might need more of the RBC folate. Something like vitamin K, often I'll see vitamin K serum check that really doesn't give us an accurate reflection of their vitamin K storage. So something like an INR or a PT might be a better reference range for those. And vitamin B12, if we can include the functional marker methylmalonic acid, this really helps us have a more reliable status of what vitamin B12 actually looks like. Keeping in mind when we do these tests, I would advocate that a patient withhold any vitamin, mineral, or even if they can, supplements like an oral nutrition supplement that have a lot of these vitamin minerals in them, because we can actually see false reported labs. So water soluble, like our B vitamins, definitely can be falsely elevated, but we can also see this in our fat soluble vitamins as well, and certainly in our minerals, depending on hydration status. So, in summary, lab interpretation can be pretty complicated. So, things that distort our lab accuracy are going to be stress, inflammation, infection, supplement, certain medications like metformin, which can cause malabsorption of B12. There's also positive and negative acute phase respondents. So, in the setting of inflammation, ferritin tends to increase. This might mask iron deficiency because an elevated level might be shown in their serum values. Hepcidin, ferritin, fibrinogen are all acute phase responders that in the setting of inflammation, the liver actually boosts the production of these proteins. And this can create a misleading impression of iron status. So iron in the form of ferritin or transferrin may actually look normal, or more often ferritin is going to be falsely elevated. And it can be quite high. I've seen levels in the 2000s that were more indicative of inflammation than their accurate status. Albumin and pre-albumin has been used, I don't know, for decades for nutrition markers. But we know because albumin and prealbumin are affected by inflammation and fluid shifts, they're not an accurate reflection of nutrition intake alone. And they're not very reliable at all for nutrition indicators. Transferrin can drop as iron panel interpretation or as iron stores aren't available. So if the liver is sequestering iron and then we have a low ferritin, but it shows up as a high ferritin, transferrin may actually drop, and that might complicate our interpretation of iron deficiency. Retinol binding protein can falsely lower vitamin A levels, and then zinc can actually redistribute to our liver, and this can also show a false deficiency. One thing I didn't list here is if we're looking at liver enzymes, if ALP is low, it could be an indication that zinc is deficient. So if you see that and you have no other explanation, it's probably worth checking a zinc panel. So putting this all together, again, I realize a lot of my slides have a lot of information, but I really want you to have a tool to take away to refer back to because I realize it's a short period of time and it's really hard to capture all of this. So a complete assessment really connects all of our symptoms. We get a really accurate intake, or as accurate as possible. If we have access to do weight body composition, great. We can look at micronutrients and their risk and any comorbidities that help answer, for me, two really practical questions. What does intake look like, and what's the safest next step? This also helps us hopefully prevent any false reassurance from a stable way to routine labs and helps us prioritize functional nutritional status. And then in severe cases, this framework can actually support a timely escalation to advanced nutrition support like enteral nutrition or parenteral nutrition. Also, if a patient needs IV hydration as well. So let's go ahead and transition from assessment to action. So our gold standard nutrition plan is the gastroparesis diet. And I use the section symbol around diet because I don't particularly care for the word diet, despite that my professional name or position is a dietitian. I find for some patients this really is intimidating. It can lead to some misconception that this is a short-term solution. So rather, I try to reframe it. I try to tell them that it's less of a fixed diet and more of a collection of flexible principles that we can tailor to them, specifically their symptoms, their intakes, their preferences, etc. So the gist of this diet are small, frequent meals. It's advocated to eat 5 or 6 per day. Texture modifications or the small particle food plan, low fat intake, which is advocated to do take in less than 50 grams per day, low fiber, less than 15 grams per day, and adequate hydration, aiming for 6 cups of hydrating per day to maintain intake. That said, oops, too many slides, sorry. Oh, I seem to be missing a slide. Oh, here we go. It's just in the wrong order. So all that said, evidence versus reality are two very different things. So someone may do really, really well with eating 4 times a day, eating 7 times a day, following a very low-fat diet. I would argue that this is really hard to do. Patients have jobs just like we do. They have children, they have lives. It's really hard to stop and eat 5 times a day. So a lot of these patients don't feel well, so they don't want to eat 5 times a day. So it's really hard to adhere to that kind of plan. Most of these patients are underfed. Some of them have as low as 40% of their energy needs coming in, and often protein's inadequate. It can be the really hardest for them to tolerate. So we need practical guidelines to help navigate our evidence, is what I'm getting at. The other thing that's really concerning for me is when we're frequently eating, this actually can hinder our migrating motor complex. So when we aren't at rest, our migrating motor complex is not functioning at its peak. So we actually can have this sweeping mechanism that's helping with motility. It actually can be impaired, which may actually exacerbate their motility. I'm going to back up because I realize I went in the wrong order. So stages 1 through 3, we see this a lot, or I see this a lot in a lot of education. I have some references at the end for some open sources. I like to use this as a framework. I don't like to present this to patients and say, this is what you have to do. You have to start with stage 1, then move to stage 2, then move to stage 3. That could be appropriate for someone. Maybe they present to you with incredibly severe symptoms, and we need to start them at the very lowest risk of entry for them as a plan. I do always emphasize and am really explicit with my patients that stage 1 is not nutritionally complete, and we really should not be following it more than 2 days. I will go as far as 3, but this requires very close follow-up, which might not be applicable in your clinical setting. Stage 2 is more of our blenderized soft food, so this is more of the small particle diet. This might be where we see the biggest gain in energy because patients can actually increase the density of what they're eating without increasing volume too much. And then stage 3 is our maintenance pattern, which would be the ideal circumstance, but patients may bounce back and forth between stages 1 through 3, depending on where their symptoms are. But generally, in a maintenance pattern, we have really well cooked, low fiber solids as tolerated. We adjust portion sizes as needed. And this can just be a tool that patients can cycle through when they're navigating wherever their symptoms might be. So, hydration is something that can be incredibly complicated for these patients. Again, I realize a lot of information on here. So, for anybody who likes to geek out about the science, I listed like the osmolality of our fluid. So, hypotonic, isotonic, hypertonic, and I broke this down to mildly and highly hypertonic. We would assume that someone can tolerate plain water, but I would say 9 out of 10 of my patients refer to plain water as feeling like it sits in their stomach like a rock. So this could be the rate with which it empties out of the stomach. And this could cause a lot of this like sloshing and over fullness that patients tend to describe when drinking this fluid. Isotonic seems to be a bit better. So these are going to be like electrolyte beverages, sports drink, could even be milk because it has some electrolytes in there. They might be better absorbed, and it could be because sodium and glucose support absorption, and it's less of this rapid emptying that can be this sloshing situation. The mildly hypertonic and highly hypertonic, I don't use these with my patients because there are concerns about how quickly they can increase blood sugar. Of course, it's sugar sweetened beverages for most of these, so I don't advocate for those just in general as a dietitian. But some patients say they tolerate these better. So I have patients who say I can do really well with soda, but I can't drink water. So I try to meet them where they are, and I try to advocate for something that's not sugar sweetened. And maybe we can like meet in the middle to make sure they're hydrated. So the next thing is moving into like a meal pattern example. So I wanted to give you some examples of what a day could look like if we are eating solids, what a day could look like if someone is having to do more small particle and liquids, and then what a day might look like with severe gastroparesis. So day 1, and this is of course not in any order, it's just an example. This could be front loading solids earlier in the day. So one of the common themes that I see with patients is they say my symptoms are the worst at nighttime. I find this to be often because they feel incredibly nauseous when they wake in the morning. They're fearful of eating because they don't want to get sick on the way to work or get sick at work, or they don't want to miss a day of work. And then they get to the end of their day and they eat their only food of the day, which could be a larger volume, or it could be a lot of foods that are heavy in fiber, heavy in fat that just don't sit well overnight time. So I like to advocate for front loading the day. So maybe they have more solids in the morning, and then we alternate things that we consider small particle, like a Greek yogurt, or they might have tender baked chicken at lunchtime with like potatoes and some steamed green beans. And then the latter part of the day, we're going to work towards more of those blenderized or liquid foods that are still really nutrient dense, but might really help them with those nighttime symptoms. A lot of these patients can tolerate certain things that we might say aren't tolerable with gastroparesis. So I have patients who do really well with soft fruit. I have patients who do really well with a lot of varieties of vegetables, proteins, etc. So this is where creating that tailored approach is really important. Realizing I need to speed up so that we have time for questions. So alternating small particle meals and high calorie just simply is um, kind of that 5 to 6 meal reference, but what we're doing is solids, and then we're supplementing something like a homemade protein shake or an oral nutrition supplement. These generally empty much more rapidly so that patients don't feel full for an incredible amount of time, which can help them have solid foods throughout the day. And then lastly, this might be for our patients who have really severe gastroparesis. They may need blended and liquid foods. So we might need to give them things like high calorie nutrition supplements, smoothies, blenderized drained soups, etc. So common misconceptions, I think this can happen both with our patient and also some misinformation that maybe they're given in the clinic, either, I don't know, antiquated education or whatever might be available to the patient, or it simply is just not a lot of information. A lot of these patients are what I would call like our type A star patients. They want to do the best. So they might interpret eating healthy as I have to have high fiber, I have to have high volume. I need to eat things like salads because I'm not healthy if I don't have those things. But sadly, folks don't tend to tolerate those. Eating that large meal at the end of the day because they want to catch up because they missed food. Over restricting, this might be something they find on an online forum or a book where it's like, oh, the gluten-free diet works for gastroparesis or low FODMAP. In the end, whether this helps or not, it just leads to a lot of restriction and then more fear of trying to bring food back. Some patients drink really large amounts of fluids with their meals, and they don't find that problematic, while others really do need to sip in between to help with volume control. Okay, so this is just to say that symptom improvement after gastric stimulator or enteric therapy does not necessarily indicate normalization of gastric emptying, also doesn't replace nutrition management. So before surgery, ideally we want to optimize the nutritional status. So if we have a chance to look at their weight trends, their current dietary intake, do they have any micronutrient deficiencies? We want to correct these before they go into this procedure. Coming out of the procedure, generally in the immediate phase, postoperative window of 1 to 7, patients can expect some level of nausea, some level of pain. Not all patients, but I think it's really important for us to give those expectations that this could certainly happen. So as a goal, we want to prevent hydration. We want to help them with wound healing. We want to advocate for a transition back into oral intake without going too quickly. Patients get really eager about going back to like solid foods. And then monitoring these folks over 2 to 6 weeks. So it can be really helpful if a dietitian's involved in this. But I will say patients can kind of dance between these levels depending on how quickly they're advancing or what their symptoms are like. So I often refer to this as like 2 steps forward, 1 step back. So progression from liquids to puree to solids is really common and it can happen a little bit too fast. But this is incredibly linear. Patients might start with puree and they might go straight to soft solids. Okay, so just as a summary, recovery is not linear. We need to plan for fluctuations. And if we can optimize during the pre-op period with things like protein, hydration, and immunotherapy beverages, that could be really helpful. And I realized I didn't put that in the resources, so I'll have to add that to the slides. So I'm going to skip through to our case study. So I really like this case study. This is a young female patient who, when I first saw her, she had unintended weight loss of 28 pounds over 8 months. She was diagnosed prior to meeting with me with severe idiopathic gastroparesis. She had 78% retention at the 4 hour mark, according to her gastric emptying study. And when I started working with her, she had really persistent nausea, abdominal pain, early satiety, discomfort, and bloating. Her caloric intake was very, very poor. She was only taking in around 800 calories a day, and she relied mostly on liquids, and she could have some crackers, which she said helped with her nausea. She had a ton of food anxiety and fear, so she didn't want initially to try any kind of food. Lots of micronutrient deficiencies that we had to correct. And because of her dysautonomia, she actually has a port and she had to use IV fluids, which actually turned out to be a great resource because she advanced in her nutrition therapy. So she met criteria for a GJ tube, but sadly, it wasn't tolerated. She had significant pain. The formula wasn't tolerated. So we actually had to remove that and transition her to parenteral nutrition at home. She was on this at 100% for a period of time. Then she underwent the stimulator placement. Initially, she developed some reactive hypoglycemia, which till this day we can't really explain other than just the inflammatory process of the surgical procedure itself. And then over time, with the gastric stimulator, her nausea decreased to such a level that her oral intake is better than when it was when I first met with her and before we had to do advanced therapy. She still uses TPN 1 or 2 days a week, but we're nearly at the place where she's completely oral intake. So I would just mention the goal is not to create a perfect gastroparesis diet. And this is where I tell patients I don't like to function in the black and white. I like to function in the gray, where we give them very individualized plans. So we can present someone with a piece of paper that doesn't really tell them anything. So when we have the time, it's really great if we can preserve intake, prevent restriction, support their function. Can we start with what they're tolerating? Can we just adjust the symptom response by changing up the amount of the texture of the food? And then can we evolve that over time? Can we ask questions like, what are you currently taking in? What do you feel like is a trigger? Are you able to maintain your weight? And then observe patterns over time that could be quote unquote merely good and bad foods, but they certainly aren't. They're things that the patient can tolerate. So food choices and calorie strategies, patients often really struggle with getting in enough. So replacing some of their calorie and protein through like oral nutrition supplements, or it could be like a smoothie or yogurts, things that generally empty faster and then don't sit as heavy volume in the patient. So we might have to increase calories with necessarily increasing portion size. So a 4 ounce smoothie, we can pack that full of calories and protein. A plan for bad days. This is really hard, but patients tend to get, like I said, they kind of oscillate between being really well in maintenance and then they have like mild symptoms. They might have severe symptoms. So just helping them understand that there are backups. Maybe we refer back to the stages 1 through 3 and give them that tool to say, okay, let's do a little bit of what I call a gut reset and let's do stages 1 for a couple of days. And then how do you feel? Can we progress to stage 2? Keeping hydration as a strategic measure, so sipping fluids, what's the best fluid that they can tolerate? Is it not water? Okay, great. Can we find something else? And then things to watch out for, like are they losing weight without trying? Are they not eating enough? Are they frequently vomiting, dehydration, etc.? The open sources, the resources at the bottom are a little too small to see, but the IFFGD, which forgive me, I'm forgetting what the acronym is, has a great open resource. The University of Washington, University of Michigan is a really great resource for gastroparesis education. They also have a really great Instagram and Pinterest account. So if patients have social media, it's a great place where they can go and get recipes, they can get ideas for foods, they can look for products that might be really helpful that they can just pick up on the shelf. And then this video on the left, it's hard to see, but it's actually for folks with diabetes. And it's a really great informative video. Pending time, you may or may not have time to show this in your clinic, but it could be something that's really helpful to share with the patient. Clinical takeaways. So nutrition, our first line of therapy. Assessment can reveal hidden risks, so it's really important that we do a comprehensive evaluation. Least restrictive plan wins, so we want to make sure that we really preserve and provide the widest variety of foods to limit fear, limit malnutrition risk. And then we have to be really flexible. This is not linear. Patients are going to ebb and flow, and so we need to be able to help them manage that. And then advanced therapies. are great. They help these patients manage symptoms, but that does not mean that we still don't need a nutrition plan. All right, I hope I finished with enough time for us to have questions, and I'm sorry I flew through that last part.
Ashley, that was incredible. Just like you said, a treasure chest of information and knowledge that you have and that you had here. So, um, and I know you did fly through it, but we will have a recording available in the near future for folks to catch up on. And it sounds like we can provide the slides as well. But we do have some questions that came in the chat. Let me just make sure I can pull up this first one here. Okay, so looking back, Ashley, at the beginning of your career and managing gastroparesis patients, what do you know now that you wish you'd known when you first started?
Oh my gosh, everything. I think the most important thing for me that I've learned is meeting the patient where they are. That yes, we have evidence. Yes, we have sort of this script to go by, but patients rarely fit into that script. So using the evidence as a tool, but making it really flexible for what works for them so that we can manage this the best that we can. So, really paying attention to where they are, what their fears are, how we might navigate those, and how we can get them to be okay with food for something that's been really scary.
Excellent. Thank you. There's a lot to learn over the years. Okay, another question. Could you give some specific examples, several specific examples of the fatty foods to avoid?
Mm. So I'll break this down in two parts. In general, fatty foods that are solid are going to be the most difficult to tolerate. And this is even lean protein. So a piece of chicken breast, there could be enough fat in that solid piece of protein. It's really hard for that to break down with peristalsis and also empty out of the stomach. Other things would be like butter, surprisingly, which is not solid at room temperature, but that actually can empty really slowly for some patients. This could also be like red meat, pork, so a lot of protein that's really high in, well, variable fat levels could be enough. Eggs, I find, can be really challenging for patients, just the egg yolk itself, even though when we look at grams of fat, it's not a lot, but it could be enough that it delays their stomach emptying, that maybe they do better with egg yolk or egg white. Liquid fats, even high fat, tend to be really well tolerated. Milkshakes, smoothies, yogurt, cottage cheese, those tend to empty much better and are more tolerable for fat.
Okay, that's great, helpful. So similar to that same kind of vein, and you talked about some undernourished patients that you've seen, but how do you counsel the obese gastroparesis patients?
It's really complicated because they come into this with a lot of emotion. So sometimes the initial counseling is really just hearing them, hearing if they've experienced this weight stigma, and building that trust with someone where they come into a dietitian. And I'll be really frank, our field, it's a lot of very fit, lean, thin females that don't look like our patients. So they have a bit of a barrier coming in that we're going to judge them for what they look like. So building that trust is where I start. And then I look at weight trends. Are they someone who have lived in this body for a very long time? Have they always presented overweight? Or are they someone who's gained weight over time? So if it's the latter, then I try to break down barriers of it's not their fault that they've gained weight. This is a metabolic issue. They've really struggled with food intake. They've had to rely on very caloric dense foods that sadly manifest as storage of fat because their body's in a constant conservation mode. So it's kind of how I navigate that with patients. Do patients need to lose weight? That's a huge question, right? Because we know with research, if patients lose body mass, their symptoms are better. But I have to make sure that a really great nutritional status, we can have them in a maintenance phase before I even consider navigating what that might look like.
That's helpful. Thank you. Okay, another question here. Someone has shared that symptomatically, one symptom that they see overlapping with chronic nausea and vomiting syndromes is effortless regurgitation, rumination, along with their background vomiting, typically preceded by nausea. Do you treat these patients any differently from a dietary perspective when present?
In general, no. I treat them the same as I would any of my patients with gastroparesis. For those that have, say, silent GERD or have any esophageal diameter strictures. So they have gastritis that's limited the diameter. I might focus on teaching them about we need to make sure the diameter of the food fits the diameter of whatever part of the intestine, the GI tract is. So if someone has a narrowed esophagus, if they have a space in their intestine that's narrowed, maybe because of adhesions, then we'll focus on that.
Great. Thank you. All right. We have lots of questions in the chat. This is great. Okay. How do you manage patients who have both gastroparesis and constipation, where increasing fiber may worsen those gastric symptoms?
I think it's really important to have a collaborative team here so that we know, is it functional? Is it structural? Is it just pelvic floor dysfunction? And we can throw all the fiber that we want at this person, and it's not going to help alleviate constipation. I will advocate for fiber, but I have to find what works for that person. So if they're one of my patients have more milder symptoms and they do well with more solid foods, I might incorporate more high sorbitol natural sources like peaches and plums and nectarines, or maybe I get them to eat prunes. That can be a really natural way to help with laxation and stimulate a bowel movement. I can use fiber supplements. Sometimes I do. If they have a lot of bloating distension, despite psyllium being my top choice, I won't introduce that with patients. Partially hydrolyzed guar gum, one of the most popular brands is Sun Fiber, can be a really gentle, non-fermentable fiber. Patients can mix it into their foods, they can mix it into their smoothies, they can mix it into tea. It's really dissolvable. So it's not something they have to drink with excess water. They can use their food as a place to really take that in. And I have really good success with that. But some patients do need osmotic laxatives. Some of these patients need Miralax. Some of them need magnesium. So it might be a dual plan.
Okay. That makes sense. Again, going back to your tailored approach, depending. Yes.
Mhm.
Um, okay, let's see here. What are the most common nutrition-related red flags that suggest a patient with gastroparesis needs more aggressive intervention?
I would say someone who has persistent daily or near daily vomiting. Someone who's having diarrhea and they're losing a lot of fluid. Plausibly, they could also be losing fat-soluble vitamins depending on the rapid emptying, because we can have both delayed emptying of the stomach and rapid emptying of our intestines. So it can be really difficult to manage. So those will be my red flags. Anyone who has an eating disorder history, red flag only in the sense of where are they in recovery? How confident do they feel about dietary strategies? But red flag for me because they tend to have lower bone mineral density, tend to have higher risk of nutrient deficiencies. And then there could be the functional aspect of pelvic floor dysfunction if there's someone whose eating disorder was heavily laxative use.
I see. Okay, that's helpful. All right. I think we have time for a couple more. So let's see. We have, uh, excuse me, gastroparesis patients can have POTS. How do you handle these patients with increasing fluids, where increasing fluids are prevented by their gastroparesis?
So if we go back to that slide again that had a lot of information about osmolality, I find a lot of my patients who have POTS are pretty well tolerant of like an electrolyte solution. So
Mhm.
we still might have to tailor around food is volume, liquid is volume. So I might teach them you can drink them until you eat. Don't drink anything while you're eating unless you just need sips to help swallow. And then wait 15, 20 minutes after you've had your meal before you resume hydration. This really helps dedicate volume as best as we can to the stomach so we can have best of both worlds, hydration and food. Water tends to be the worst and they need more water, but they also need quite a lot of salt to help manage POTS.
Mhm.
So an electrolyte solution, adding a lot more salt to their food might be the best way to help them manage POTS.
Okay, thank you. All right, I think we have time for this one last question. And if we didn't get to all the questions in the chat, we can connect you via email with Ashley after this, so that way you can get your questions answered. What key information should providers gather before referring a patient to a dietitian?
Great question. If you can, a food intake, right? Like 24-hour intake, maybe that's part of their intake, or you send that after your visit. A micronutrient panel, if you can put some of those more key vitamins and minerals that I mentioned, like iron, B12, thiamine, things that wouldn't be in a standard metabolic panel, having those already done can be really helpful before referring. If you can assess malnutrition risk, I realize this is asking a lot, but that can really help us gauge what level of risk they might be and how immediate we need to treat them. And then, of course, this should be in the chart, but like medications, are they presently working with other providers like a cardiologist, an immunologist, a neurologist, pelvic floor physical therapy? So that really helps us collaborate with a team, can tell us like, okay, what are you all doing so that I don't overlap or I don't contraindicate something that's been done or is being done.
That's
I
great.
hope I answered that
Yeah.
question.
Yes, yeah, nice and a collaborative approach makes sense. So Ashley, I've learned so much today. I appreciate it. Thank you for joining us again. I'm just
Thank
going to
you.
share my screen really quickly. For those of you interested in learning more about enterotherapy and also to see if Entera is appropriate and right for your patients, we have our online educational resource center that will provide videos and other educational material for you to check out, as well as a way to connect with our local therapy consultants in your area. So again, Ashley, thank you so much for the time today, and I appreciate everybody joining us.
Thank you. Thanks, everyone.
Thank you. Bye-bye.